So Vera Morgan is a very old friend, very dear friend of mine, and we've known each other for a long time. Vera is a professor at the University of Western Australia in Perth. She is a psychiatric epidemiologist and has been the leader of several large surveys of psychosis in Australia, including one that she'll talk about today. Vera is actually here to be a PhD examiner tomorrow at Risco Hospital. So it's just fantastic, Vera, that you could be here to talk at our meeting as well. So 2 for the price of 1. And it's also another great way where we can bring our, have more Australian and Danish interchange. So Vera was in charge of this study looking at the survey of high impact psychosis, and our group in Brisbane was one of the sites that recruited for that study. And I've asked Vera to talk a little bit about, we've heard from the last 2 speakers, comorbidity within mental disorders, and now we're going to break out and look at comorbidity, and the subsequent speaker also, Joan, after Moreta, about mental disorders and comorbid general medical disorders. And by the way, Niels Bohr, we will do this. We'll be advertising for another postdoc in a year or so's time, and we'll be doing disorders in good time. But Vera, please tell us a little bit about what you found in the SHIP survey. Thank you.
Very much, John, and especially thank you for the honour of being able to present these Australian data at the Niels Bohr Symposium. What I'd like to do this afternoon is provide a very brief background to the survey and very briefly talk about the mental health profile of our survey participants, but then move on to their physical health profile. And what I want to do is use evidence from the survey, not only of poor physical health, but contributing factors to that poor physical health. And then I want to look at other factors that may indirectly impact on physical health. And finally, I want to ask the question, given all this, what are the challenges for service providers in improving the physical health of people with psychotic illness? So we undertook the national survey in 2010, and its aim was to estimate treated prevalence of psychotic illness and to describe the profile of affected people. We collected nationally representative data using a 2-phase design, drawing from population catchments covering about 1.5 million Australians aged 18 to 64, which is about 10% of the population in that age range. Our census was with people who were in contact with public specialised mental health services, so that's inpatient services, outpatient, ambulatory and community mental health care services, as well as non-government organisations supporting people with mental illness. Out of 8,000 people who were screened positive for psychotic illness in the survey census, we interviewed 1,825, 60% of those were male. And we collected over 1,500 data items on many aspects of their lives. Just very briefly to give you a sense of the diagnostic profile, you can see here that about 63% of people had schizophrenia or a schizoaffective disorder, and we've got about 10% here at the end who had psychotic features to their illness but didn't meet full diagnostic criteria for an ICD-10 psychotic disorder. Looking at their symptom profile, and when I'm looking at the past year, the majority of people, not unexpectedly, 61% with delusions reported in the past year, 56% with hallucinations, a third reporting subjective thought disorder, and a quarter irritable or elevated mood. But looking here at the comorbidities, 60% with symptoms of anxiety and 55% with symptoms of depression. We also collected data on negative symptoms. We had 6 negative symptoms that we enumerated. 85% of our participants named at least or one negative symptom, but we had about a quarter who had 5 or 6 of those negative symptoms. And this is the last slide on the mental health profile, and it's one of my favourite slides in a way. This is looking at global independent functioning using Judith Yeager's multidimensional scale of independent functioning. So this is how they're doing relative to the general community. And what we find here is that about a quarter are significantly, extremely or totally disabled. But when we look over to this side, about a quarter are normal or just mildly disabled. And I'm a little bit disabled myself here, so I'll... And what I really like about that slide is that it shows the huge variation in outcome for this group of people, and that basically the huge variation in the sort of interventions that are required. So moving on to the heart of what I want to talk about, which is poor physical health, and I just want to acknowledge some of the population comparisons that I have, which were provided by Tim Slade, who undertook the, with a group of people, the 2007 National Mental Health Survey in Australia, and he was able to provide snapshots within the same age profile as our own population. So what's the evidence for poor physical health in this group? I'm going to start at the extreme end, and I'm looking here at data that John and Sukanta Saha produced using the screening population data, looking at mortality, and they did their modelling. They expected 16 deaths and found 65 deaths, so they had a standardised mortality ratio of 5.5. In an ongoing project that we've just been funded for, we've actually collected the mortality data for all 1,825 people in the survey. So we will now be actually sort of looking at the mortality within that group, but we will also have the clinical profile that we've collected so that we will be able to look at some risk factors and model those in the data. Suicidality and self-harm. I've got a number of slides where you'll see the blue here, or the teal for the psychosis survey, and the population data will be in the grey. We can see that 50% of our participants reported a suicide attempt over a lifetime, and this was over 10 times what we found in the general population. 17% reported deliberate self-harm in the past year, and half of those had to be hospitalised as a result of that self-harm attempt. And here again, still at the other extreme end, abuse and assault. 31% of our participants reported childhood abuse, and this is abuse we recoded to make sure that it met Australian Department of Child Protection criteria. And this is twice the proportion that you might expect in the general community. And then we asked about victimisation in the year prior to interview, so adult victimisation. And here I'm presenting the data on actual assault. 17% reported actual assault compared to 3.4% in the general population, so 5 times the population rate. And what I need to add here is that victimisation is, on the one hand, it's a health condition, but it's actually a contributor to the poor outcomes that we see. Now moving on to sort of more standard physical health conditions, we've got here again, you can see the psychosis survey population in the teal, and in grey we've got the general population. And you can see in all these physical health conditions that we were able to compare that the rates were higher in people with psychotic illness compared to the general population in the same age. The only condition in which it wasn't higher was cancer. And I've pointed out just a few in particular, like heart and circulatory conditions, diabetes, kidney disease and stroke. We were particularly interested in looking at metabolic syndrome. Metabolic syndrome's characterised by insulin resistance, and it's associated with a 5-fold increased risk of type 2 diabetes, a 2-fold increased risk of cardiovascular disease, and of course with that associated risk of mortality. We found that 58% of our participants met harmonised criteria for metabolic syndrome, And that compares with 29% in the general population, but in the general population, the only data we could have was for an older age range. When we looked at the individual criteria, and we looked at sort of the proportion meeting threshold, 82% met threshold criteria for waist circumference. We had about 50% each for HDL, cholesterol, blood pressure and triglycerides, and about 29% for plasma glucose. What I want to present in this slide is some quite elegant work that was done by Deb Foley and Andrew McKinnon. So they took some of the individual criteria for a metabolic syndrome, and they wanted to model them by age and sex and compare that with the general population. I'm going to show the data here for the waist circumference, but they found a similar pattern for all the other criteria that they examined. So let's just take you through this slowly. I'm looking at males here. This dotted line here, that's the threshold. In blue, you've got the general population, and in pink, you've got our psychosis participants. And what you can see here with the general population is that males cross the line somewhere around mid to later 30s. Amongst our survey participants, males on average had crossed the line before the age of 20. When we look at females, we see a similar pattern, but a larger gap. So in the general population, women were crossing the line somewhere between 30 and 40. When we started surveying our women, they were already aged 18, and already on average, they had crossed the threshold before that age. So there's some of the physical health outcomes, but what are some of the contributing factors to those that we recorded in our survey? So substance use. So here we can see, we're looking at current smoking here. Rates of current smoking were 2.6 times the rate in the general population here in grey. Lifetime alcohol abuse dependence, 2 times the rate. And lifetime illicit drug abuse and dependence, 6 times the rate. When we look up above, what we've got here is data from the first survey that we undertook in 1997 compared to the 2010 survey. And what you can see is that rates of smoking have not changed at all. That lifetime alcohol abuse and dependence has gone up over the 13-year period, and that lifetime illicit drug abuse and dependence has gone up. And this is in contrast to what's happening in general population data. Body mass index. We found that 45% of our participants were in the obese range compared to 21% in the general population. And when we looked at physical activity, a third was sedentary compared to 18% in the general population, and there were very few who were in the moderate to high activity level. We know that many of the medications that people are on have a weight gain profile, and we asked, and we had 92% of our participants were on medication of some sort, and about 82% were on antipsychotics, and so we asked them for record the side effects that they were experiencing. So you don't need to go through all of these, but the third top side effect is this increase in weight over the past 6 months, which was medications related, and 38% described that with a mean weight gain over those past 6 months of 9 kilo. So we wanted to know what were the modifiable risk factors that were associated with metabolic syndrome. So we wanted to analyse key modified risk factors, including current smoking, body mass index, sedentary activity level, low fruit consumption and low vegetable consumption. So we basically put all of this into a multivariable model, and when we did so, the significant modifiable risk factors that remained were current smoking and body mass index in the overweight and the obese range. And what happened, we then adjusted for a whole range of things, including medication use, cognition, diagnosis, age, sex, illness duration and socio-economic status, and that pattern remained unchanged. So what we've got here is the two modified targets for intervention, even though I think we would all agree that they're not actually very easily modified, but they are modifiable. The last contributing factors I want to look at are more systemic ones. So the first is that physical health is under-detected. The graphs here, this is data from the first psychosis survey in 1997. These are data from the second psychosis survey in 2010. We're looking at the proportion reporting having had a physical examination in the past year. And you can see that over the 13-year period, these are cross-sectional data, the proportion had dropped from 80% to 66%. And the proportion reporting a blood test had dropped from 83% to 65%. We were really surprised with those data because we knew that services were really conscious about physical health in people with psychotic disorders, and particularly with the medications that they were on. But in the service utilisation data that I'm not presenting today, what we saw was a very, very large drop in the proportion who had had any inpatient admissions over the past year. And we know that the physical examination is very much a mandatory part of the admission protocol, and this is something that's much harder to do when somebody's attending community mental health. So I think this slide doesn't reflect that services don't care, but it's a bit harder for services now than it ever was before. The second thing, and this is work that Cherry Galletly did, she looked at various conditions, hypertension, diabetes, hypoglycemia and dyslipidemia, and she looked at the proportion who were on medication for their condition, and basically she found sort of a big level of under-treatment, with only 52% with hypertension on treatment for that hypertension, and the percentages were 40 for diabetes and hypoglycemia, and 39% for dyslipidemia. Finally, I think that physical health in this population is under-researched. So you saw the slide that from Deb and Andrew's study where we looked at waist circumference, and you could see that compared to the general population there was a very early elevation of cardiovascular risk factors there. They also showed that the peak prevalence of diabetes was 20 to 30 years earlier than expected, and they found a very different pattern of correlations between risk factors to what they found in the general population. And all of this suggests that the current cardiovascular risk prediction instruments that we use, they may be quite unsuitable for people with psychotic illness. So it's time to have a little break. People might sort of show slides of their family now, or slides of where they come from. And I want to start, we've talked about Aarhus in Australia, but I've got a very specific question, which is, what does Aarhus, Denmark have in common with Perth, Australia? So I'll just show you, this is Perth here. Perth is called the most isolated capital city in the world. It's surrounded by the Indian Ocean and desert here. All the other Australians live here. There's John's here in Brisbane, Sydney, Melbourne and Adelaide on the east coast here. But there's one very specific thing that, yes? Yes, very good. So, sculpture by the sea, you're top of the class. Every year in Perth we have sculpture by the sea. Here at this little suburb really, Cottesloe, which is on the seaside, and you can see some of the sculptures here. And I believe in Aarhus you have it every 2 years. So I thought just very quickly I'll take you through just a few sculptures to sort of loosen up your brain, and then we'll go back to the hard work again. Of course, a lot of these sculptures come from around the world, like these android babies from David Cherney from Prague. Very beautiful, in a very beautiful setting. Okay. I want to look at some other factors that may impact as well on physical health, but less directly. So when we look at financial problems and unemployment, and what we have here is we've got 85% of our participants were on a government pension, and 3/4 received less than half the national estimated average disposable income. When we looked at paid employment, only 1/3 had any form of paid employment at all during the past year, and that dropped to 22% at the time of interview. And this compares with about 72% in the general population. When we look at education, only 1/3 had completed their final year of schooling, and this compares with about 53% in the general population. We looked at cognitive impairment. We collected cognition data using the NART to measure premorbid IQ, and what we found was that the mean was a little bit below the population mean, but it was still within the normal range. We then looked at their current general cognitive functioning using a speed of processing task, the digit symbol coding task, and here we found that their mean cognitive score was 1.6 standard deviations below the population mean. And so a little hesitantly we kind of suggest that maybe we see some cognitive impairment prior to illness onset, but certainly this has become amplified over the course of illness. And I think this is probably one of the most important slides in terms of indirect effects. So this is the age at onset slide. So the mean age at onset was 24 years. But what you can see here is 2/3 of our participants had their onset before the age of 25. And what's really important about that is that their onset was a time when they were basically consolidating their life skills through employment, education, and in developing long-term social relations. Other factors, loneliness and social isolation. So 63% reported impaired social functioning in the past year. 69% said that their mental illness made it hard to maintain relationships. 1/4 felt socially isolated and lonely, and 13% had no friends at all. Jo Badcock reported a rate of general loneliness which was 80%, and when she compared it with the estimated prevalence in the general population, that was 35%, so quite a lot higher. What Jo has also shown in work that's under review at the moment is that loneliness was associated with an increased risk of metabolic syndrome and with an increased risk of all the underlying measures within the syndrome. The last of the other factors that I'll present will be housing. So 1/4 were on a public housing wait list. 27% had changed accommodation at least once in the past year, and that's not including hospital admissions. 4% had moved twice, 7% had moved 3 or more times, and 1/4 had expressed a fear of being homeless. And that fear was not ungrounded. When we looked at homelessness in the data, 5% were homeless at the time that we interviewed them, and this compares with 0.5% in the general population. But as many as 13% had reported homelessness at some stage during the past year. And for those people who had reported homelessness, it wasn't just over a short period, so you can see a mean number of 155 days, but a high median of 99 days. So, I said I would finish by asking what are the challenges for service providers regarding physical health in people with psychotic illness. I think the challenges are these. We have a very poor physical health profile that includes high prevalence of risk factors, high risk factor thresholds exceeded at a very early age, and evidence of under-detection and under-treatment. We have also a complex clinical profile, which is complicated by high levels of social isolation and dysfunction, substance abuse, childhood and adult victimisation and their sequelae, and chronic social advantage. And that chronic social disadvantage captures appalling social circumstances relative to the general community, and we saw this especially with respect to employment, education and housing. There is an encouraging note in the data, and I think it's a really important one. We were able to compare satisfaction and hope in the survey in 2010 with what we saw in 1997. Now, when we looked at satisfaction with life as a whole, it hadn't changed much. It had gone up a bit. 47% said they were satisfied or mostly satisfied with life as a whole, compared to 42%. But 71% said that they were satisfied or very satisfied with their level of independence, compared to 58% 13 years ago. And 25%, compared to 42%, said that they needed services that were either unavailable or unaffordable. So I think that they're encouraging statistics, and I think a lot of work has gone in from a lot of various, not just service providers, but very many supporting organisations to bring about that change. In a question that we just asked in 2010, do our participants believe that their circumstances would improve over the next 12 months? Well, 77% said yes, despite what they had described in the course of the interview. So I think then that for these circumstances to alter substantially for people with psychotic illness, we basically need to take a holistic and an integrated approach to recovery that targets mental and physical well-being, quality of life and social circumstances. And I want to finish with this quote, which is from Asen Jablonski and Norman Sartorius, because I think they put this much better than I could when they wrote that the erosion of social support systems likely to be associated with the processes of globalisation should be a matter of grave concern. The sobering experience of high rates of chronic disability and dependency associated with schizophrenia in high-income countries, despite access to costly biomedical treatment, suggests that something essential to recovery is missing in the social fabric. So I want to end by just acknowledging the SHIP Technical Advisory Group, which included John. John was a site director and on the Technical Advisory Group for the 2010 survey, but also way back in 1997. John's been around for a long time, but also all the other people who were involved in designing, planning, executing the survey, and then working on the analyses afterwards. And I want to finish with this Mongatuk. I didn't know how to say it, but John had been interviewed on radio on Monday in Australia. It was on Australian National Radio, and the interviewer, Norman Swan, asked John to say something in Danish, and that's what he said, so I'm quoting John. Thank you.
Okay. Tusind tak, Vera. Jeg forstår lidt dansk, but Vera, that was it's nice to have a microscopic analysis of the issues now. We've been existing at the register level and the diagnosis level, but you're getting a little bit of information about what's happening to people behind the disease. And I think it's really important that we acknowledge that people struggle, they are lonely, and we fail them. So we're making good time this afternoon. We're going to have to go to our afternoon tea a little bit early, but I want to now open it up for general question. I know there are people in the audience. I met Lena before from Copenhagen. I know Moretta's done trials, and I know that and Thomas Monk-Larsen's here. The issues of years' life lost and how we intervene with people with serious mental illnesses to reduce comorbidity. We have experts in the room, and I'd really welcome your thoughts and reflections and speculations about how we can tackle it. Over to you. Who'd like to lead some discussion?
Okay, thank you for a very nice presentation. And thank you, John, for letting me speak. Some of the issues that I'm working on is actually how do we provide physical health care for people with severe mental illnesses, because it is a huge problem. Marete has been involved in a large randomized controlled trial in Denmark where they tried to provide people with psychosis to stimulate them to get more physically active, to lose weight and be more healthy, but it was really a hard struggle to motivate people to care for themselves. So do you have any comments on how do we access people and help them to help themselves?
It's a very difficult question. If we had an easy answer, we would be doing that right now. And certainly my unit doesn't run the clinical interventions. We've just collected a second round of face-to-face data on the Perth catchment for the sample. We had about 400 people that we re-interviewed, and we are looking at sort of outcomes and what were the risk factors or the predictors of outcome within the early data. And we've collected a little bit more to sort of look at impediments to picking up on physical activity, and those data are sort of being analysed at the moment. But deep down, I think any intervention has to make it easy for people with psychotic illness, and I think one way is that people have found has been co-location of services, so that if the service provision is all within the one area, it makes it very much easier than if somebody has to go from one spot to another spot to another spot. And I think it just takes a lot of input from the service providers to do that. I don't know, Marita, what do you want to say?
It is more along the same lines. It was because I reacted when you called the lifestyle factors modifiable. Because, of course, theoretically they are, but it is really difficult. And I think it is not mainly about motivation. I think it is it's about facilitating and maybe even providing something, providing healthy food instead of telling people how to eat healthy, things like that. But I think we are, especially when it comes to physical activity, I think it's really difficult to find out how we can facilitate a less sedentary lifestyle. I think we had a huge disappointment when we had the trial, because we thought that we had applied all the best methods, motivational interviewing, cognitive behavioral therapy, and also not to blame the patients for being like they were, but still we couldn't see any sign of any change.
And it was for that reason that I started with modifiable. I said it's not easily modified, and I know that. But I think they've shown that even if you can bring the weight down just a little bit, you can get some really good benefit out of it. I think there's been some studies done on that.
We were talking with Lena outside at lunchtime about maybe intervening at the general practice level or the doctor level, incentivise them to treat. So we keep thinking about getting the patients motivated, but maybe we've got to teach the clinicians. But Harvey, you've been in Canberra trying to get changes at a national level? Do you have any words of wisdom? Or, I've heard talk about paying patients to lose weight or paying doctors to provide the care, but how do you do it at an administrative level?
Yeah, you pay the doctors more. And if that's the way we've increased treatment rates for common mental disorders. You've got to somehow incentivise. I think it's partly about the doctors and the way physical medicine is delivered in fee-for-service. It's just not designed to deal with this. This is too complicated. I think you've got to do it like we do for chronic disease management plans for Indigenous Australians or where there's multiple comorbidities. But my question was actually about the cancer rate. So, if my memory serves me correctly, in the 97-98 survey, cancer was higher, and I might be wrong, was higher in people with psychosis compared to the general population, and those results show that it's lower. And given those risk factors like smoking and that, do we have any ideas why cancer might be less prevalent in patients with psychosis?
We didn't actually collect the cancer data in the 97 survey, so sort of the physical health emphasis has been really the 2010 survey. There was cancer data that were collected in David Lawrence's duty of care, and that might be the data that you're thinking of. And what they found a bit in a number of those data was that they were looking at mortality, particularly, I know this is true for cardiovascular disease, and I suspect it's true for the cancer as well, was that the proportion who were reporting these diseases was not much difference between the general population and people with mental illness. But the proportion who had interventions was much higher in the general population than in people that had mental illness. And so you ended up with sort of much higher mortality rates that were related to poor interventions rather than having it in the first place.
There's a lot of Danish expertise on the comorbidity of cancer and psychosis. Thomas, do you have some new data to suggest that people with psychosis are less likely to die from cancer as well, or a bit more? Yeah.
Yes, they have.
Flip the other way, is it?
Yes.
I think, I mentioned that we're collecting mortality data for these participants, and we've got those data. We're in the process of negotiating hospital morbidity data. This is not an easy job, but it's going ahead slowly. So when we get those morbidity data, we'll actually be able to track exactly what kind of morbidities have taken them into hospital and sort of what the final outcome's been.
Go to Rasmus in a second, but also let people know that. I was just going to say that there's some shared variance. Naomi, do you want to talk to that? So on the question of cancer, we'll come to you in a second, Rasmus.
One of the sorts of analyses we can do with genetic data is to take genetic studies which have been on a cancer cases and controls and schizophrenia cases and controls, so totally independently collected, and then use the genetic information to show actually a potential direction of effect. So I'll be talking about this tomorrow, maybe explaining it better, but those analyses are showing that the genetic factors for schizophrenia are in a causal direction for breast cancer and not the other way round.
Really interesting.
Type of new discovery pathways. Rasmus, you've been very patient here.
Yeah, I've been very. I'm a postdoc at the research unit for general praxis in Copenhagen in family medicine, and I did my PhD on weight changes and weight change epidemiology, and has been doing research in that for many years. And I also laughed a little bit when you said that BMI is a modifiable risk factor, because not only with the psychotic patients it's difficult to get them to lose weight, it's also the fact with people that are not as psychotic. And even the best and the largest lifestyle interventions that we have, where we have 5,000 people randomized to heavy lifestyle interventions, follow up 10 years, most expensive program that's not even realistic to implement in reality. For instance, the Look Ahead trial with diabetes patients, the mean weight loss is 3 or 4 kilos in the intervention group, and there's no effect on the heart outcomes, no effect on mortality or the incidence of cardiovascular disease. So the question is what we actually get out of focusing on weight loss in this group of patients. That is certainly more difficult to motivate because we may end up, as a matter of fact, putting more shame and more creating more problems than we actually solve. Not that the weight is not a problem, it's just that we don't have a good tool to actually treat it.
I think one answer to that is that we should be looking at all these risk factors not as interventions but as prevention, so we have to start working really early on that so people don't put on that same weight very early, and then it's much easier to stop weight gain than to reduce it.
I'm just going to wind up now, but I feel like we just don't have very good treatments. If we had effective treatments, then maybe all these will just sort of melt away, and or better prevention. I mean, that's the holy grail. Before I ask you to thank Vera for that really sort of impressive, very impressive scope, Vera, and I appreciate you putting that detail into the picture. I thought we'd just move forward the schedule this afternoon. It's the great thing about having single-track conferences. So we're making really good time. And you happy to have a 15-minute break and come back for the last two? You'll get away earlier, get some fresh air, enjoy the sunshine. Okay, so what I'm suggesting is that if everyone's back in here at 4:45, I can't say that in Danish. Clock and... I'm very bad at telling the time in Danish. We'll see you at 4:45, but please join with me and thank Vera very much for her presentation.